Going back to the SAT.
All right, so how long to do an SBT? How long was it again?
30 minutes.
30 minutes or less, or it's free, all right? So how much did an ICU stay cost?
Too much.
How much is it per day?
20,000.
So the first day is 10,000. All right, actually every subsequent day is about 6,000 to 7,000. All right, so 30, yeah, average day. So without event is 6,000, with event is about 9,000 per day. All right, so it costs money to stay in the ICU, but again, 30 minutes or is for how long it takes for an SBT. All right, if they pass, then we got to decide what we got to get off the pot. We can say, well, are we going to extubate or not? What do you want to do? Right? Then they may have to make a decision. Is it, should we, what's their mental status? What are they? What's their fluid status? What's their X-ray look like? What is, what do the hemodynamics look like? They look at all these other things to see if it's safe to come off the ventilator or not. Right? But our job is to do the SAT and the SBT. Right? And our goal is to extubate for 72 hours. If once they're after that, we say it's a successful intubation. If they've been extubated for 3 days or longer. Okay. So longer trials, even with harder exercise. So what's the hardest exercise to do? Was the T-piece, right? So we're doing the T-piece strategy right here. All right, so they did a T-piece, and that's where they just breathe through a straw, basically. It's like, I'm going to make my patients work, through a T-piece, and then I have confidence now they are going to do great on their own, right? When I take the ventilator off completely and they take the tube out. And they said, well, that's fine, but would you do 30 minutes or 2 hours? I do 2 hours, everybody. And they found that patients die more when they do T-piece versus 30 minutes or 2 hours. So 30 minutes is how long it is, not 2 hours. And pressure support of 8. That's where we get the pressure support of 8 at, right? So pressure support of 8 in here somewhere. So 8, and they did it over 0, but as pressure support of 8 at least, that is what we've found with best evidence that can be reliable to say that they're going to do well off and survive, right? So the T-piece patients might have survived, but they put extra stress in their body, whatever it might have been, caused increased mortality. Okay, so higher mortality when we don't use pressure support, right? And when we do it for too long, we do it for 2 hours versus 30 minutes. Okay, so when we did 30 minutes only, we decreased their chance of dying. Okay, which mode? There are so many modes. This is all kinds of different modes they did. They said, I try SIMV. I'm going to try T-piece. I'm going to try pressure support at 12. I'm going to try this one. And then there's different patient populations. Those have vented for 3 days or 1 day or 5 days. There's all kinds of stuff out there. No one's found the magic number, but we're kind of agreeable, and 80-90%, that pressure support of 8 is really where it's at, right? That is the weaning mode that is of choice. And 30 minutes, we know. Okay, because as long as you did it for longer, T-piece or 2 hours, that caused more problems. So again, how do you know they're failing SBT?
They failed to get the criteria.
Yeah, that's a very good lawyer answer. They failed to meet the criteria. Yes, that is a true statement, but they have increased what? Yeah, so they're breathing. So you have intercostals that are working really hard, right? They have abdominal seesaw breathing. These are things that are going to cause problems, okay? I realize that one's on a loop, but let's see if I can take that one off or not. All right, so I guess we're going to the next slide. So anyways, we have the other points on that slide that I couldn't skip were we want to make sure that we are doing, again, for what we're looking for, accessory muscle use, and we're looking for increased work of breathing, we're looking for increased respiratory rate, and the previous slide we had pictures of the accessory muscles, right? You have the intercostals, you have the scalenes, you have the sternocleidomastoid. All these things, if they're working extra hard, work of breathing is hard, respiratory rate's going up, that's someone that is failing their SBT. Okay, so again, there's analysis paralysis from the provider end about whether they're ready to come off or not. Can we extubate? Will they survive? Will they make it? We'll have to reintubate them, right? Is the next person coming on going to reintubate them? What is going on? So it's called analysis paralysis, right? It's another name for Netflix or can't decide, right? So I don't know what is this? What is that? Can they solve calculus? Can they do do they have upper airway swelling? Do they pass the leak test? There's all kinds of things they're going to ask, and they want to make sure everything is safe, right? And it's good they have that air of caution versus another person who's like, yeah, for sure, go for it, right? So, and you do want those guys from time to time because, we want a failure rate. You want a failure rate of about 15%, because if it's 0%, you're not extubating enough, right? That tells us that out of 100 patients, nobody got reintubated. That means you kept probably 70 of those patients on the vent for too long and caused more ICU length of stay, more disability, more mortality, and more hospital length of stay, right? So the kind of the key take-home point, though, is if they look good, it's good to try. Like you're walking on a patient and they're like, what's up? And you shake hands and like, what's going on? Your vital signs are beautiful. You're not in drips. Why are you still on the ventilator? Right? So those are, those are things like you got to try. And that's really those categories like YOLO, let's take it out. Let's try. Okay. So yeah, if you get intubated in the first place, just so you know, it's about a 30% mortality. So every out of 10 patients, if you intubate 10 patients, 3 of them will die when you intubate them. Okay. In COVID times, it was 8 to 9 when we intubated them. They would suffer and have a increased mortality, be put on the tube. So that's why they waited so long to intubate, because that positive pressure ventilation, all these things led to a downward spiral in the patient. So we just got to recognize that, for every 10 patients, 3 of them will die. And in the ICU, you're not, yes, you do save lives, but you do lose a lot of lives, right? You just got to try your best effort and do what might help. It's all a game of averages, right? Someone comes in, they have multi-organ failure, right? They're already just with 1 organ down, you're about 20-30% mortality. 2 organs down, you're vented with renal failure, 50% mortality, right? You have some heart stuff going on, you're like the 90% mortality. And if you're a 30-year-old versus 70-year-old, you're already beyond 100% mortality. There's all kinds of different strategies and Swiss cheese to make it through to get them out of the ICU. So you have to kind of recognize that too, right? And what we can do to improve their outcomes is to take the tube out, if they meet criteria. And again, there's all kinds of things that can tell you, oh no, today they have advanced age, they're 90 years old, let's try again tomorrow. It's like there's no evidence that these things are. Over here. If they advanced age does contribute to it, but over here, it's like, oh no, they're delirious today. Right? Let's try again tomorrow. Let's see when the delirium is better. Right? They got too many secretions. Let's try again tomorrow. They can cough. They can cough the secretions up. That's perfectly fine. Right? But if they are really, they're advanced age, their fluid balance is like positive 10 liters. Are they going to fail? Very likely. Right? I think it's coming up on the next slide where we have where you see that. The positive fluid balance, when you take away the ventilator, you're taking away that, it's kind of keeping things at bay, right? So when you take away the positive pressure, now everything can fill in, right? So these are things on the left here that tell us that, with evidence at least, that yes, those are things that tell you that, yeah, they most likely will fail, right? So what are some things that are like 100%, or not 100%, but are really put us in the right direction that they should come off the vent is this RSBI here. So it's Rapid Shallow Breathing Index. The ventilator will calculate it automatically for you. It'll give you the RSBI in real time. So it's R, respiratory rate, divided by breathing, tidal volume. So respiratory rate divided by tidal volume. And the tidal volume is in liters. So it's like 0.5 is 500, right? 0.350 is 350 tidal volume. So you take a respiratory rate of 30 divided by 0.35, or right here we got 36 divided by 0.25, so that's a 250 tidal volume. They're breathing 36 breaths a minute, right? And they're pulling 250 cc's. Does that look good to you? They're like, that sounds like a dog, but I'm just saying, if that's a patient on the ventilator, is that good? That doesn't sound good. And they validated that with this equation. So they said, 250 divided by, 36 divided by 250 is 140. The magic number is 105. So if you're less than 105, you have success. You will most likely come off the ventilator, like 90% chance. Whereas if it's more than 105, it's probably not the day to take a chance and see if we get a reintubation or not, right? If your RSBI is less than 105, you have a lot of confidence that they can come off the ventilator. So you can see this similar patient, they got 28 breaths a minute. That's fast. They're breathing 28 breaths a minute, but they're getting 600 tidal volumes, 0.6, right? 0.6 liters is 600 tidal volume. That's 47. That's less than 105. That's great. Yes, they're breathing fast, but they're going to pass. They're breathing 600 cc's of tidal volume, right? Yes, we have SBT failure criteria, but this we're past that. They're not desatting. Respiratory rate is less than 35, right? But they're breathing 28, and I'm not really comfortable with that. Well, what's their RSBI? RSBI is less than 105. They're going to pass, Okay, and yeah, there's other things that we can look at. It's like, oh, the X-ray is horrible this morning, and they're not putting urine out overnight. Then yeah, maybe we can maybe wait a little bit.
So that's quantified enough to.
Yeah, it has a lot of evidence behind it that it's something that we can rely on. And again, the ventilator spots the number right there. It's right. There's no reason to even have to remember it, but it's, you know, RSBI, rapid divided by breathing, or respiratory divided by breathing, but it's on the ventilator also. Like an official proper RSBI is you put them 0 over 0 and see how they do for 2 minutes, but you can get a kind of ballpark. If the ballpark is definitely like 80, 70, you know they're going to be good. Okay. And then another thing that a lot of people are fearful of, especially for reintubation purposes, is a leak test. So they'd say, hey, what's the leak test, right? So leak test means, is air escaping out of the lungs when you deflate the cuff? Is there a leak or not, right? Should there be a leak?
Yeah,
Yes, right? You should have a leak. If there is no leak, what does that mean?
They have no lungs.
No, that means that their airway has swollen around the ET tube, has swollen around the cuff, right? So we want to hear a leak. If there's no leak, they're like, oh, no, let's try it again tomorrow. And so then it puts it off another day. And then the next day, do you have a leak test? No, let's try again tomorrow. Another day, another day. So it's, you know, some people got not upset, but frustrated, and they had eustress about fixing the problem. And they said, well, who is actually the one that's, is this reality or not? Do patients actually require reintubation? Do they have the stridor and everything? Because if you take that tube out, then and the airway closes, yeah, that's serious, right? But like, can we quantify that, and can we say if it's safe or not? And it is safe when you've as long as you look at this little safety situation here, right? You have if they're intubated for more than 6 days, yeah, I'd probably be worried, and I would go through with therapy, right? Because it's been there for a long time. You can have definite bronchospasm, right? If it was multiple intubation attempts, more than 3 attempts, I believe, right? More than 3 attempts here, positive leak, extubation, right? So I thought I put it over here. But anyways, it's been more than 3 intubation attempts when they first intubated the patient. Yeah, that's someone we want to try to give them some medications to avoid the airway from collapsing, right? If they are, they're reintubated recently, they've self-extubated, they're reintubated, yeah, well, let's do a leak test to see how things are going, right? If it's a traumatic intubation, again, that's, they had all kinds of blood happening, vomit, that might be someone that you might want to wait and do some therapy. And what is the therapy? The therapy is steroids, right? And it's not like a 5-day course of steroids. It's give steroids now and pull the tube in 4 hours kind of thing. So they give the steroids in the morning. The leak test is there's no leak. Let's give a steroid push right now, like 60 milligrams or so, at a little high dose, and then let's pull the tube about 4 to 6 hours. And this has evidence behind it. It is, as long as they, don't meet this criteria, it is safe to extubate. Are you still worried? Yeah, you're still going to be alert, and you're still going to assess the patient. But we found that it's fine to do this. The other thing that has it on here, you might say women, you might feel attacked, right? So women are inflammatory. I'm not saying this to be a sexist. I'm just saying they do have more inflammation once a month. They do have all kinds of things that more inflammatory processes than a man might have. So that is something also. If they're a female, they might have a better, they have more chance of having extubation stridor, or they have extubation fatigue from a stridor process or whatever it may be. So if they do get stridor afterwards, we can give more steroids, and we can give what's called racemic epi, right? So racemic epi is just epinephrine that's been diluted down, right? It's definitely different than cardiac epi. Cardiac epi is extremely strong. You would never give this by itself, right? You only give this when someone is actually arresting. But either way, you give the racemic epi, it's a lower dose concentration, and they inhale it and it opens up the airways, okay? So that's the idea. 4 to 6 hours, we're going to, after we give a dose of steroids, we're going to pull the tube, okay? And then another thing to kind of say, hey, they're not doing great, or they're borderline, RSBI is like 100 or 110, well, we can extubate them to BiPAP, right? So that's always something we can suggest, or they can suggest, and say, a COPD patient or an obese patient, they might benefit from that BiPAP therapy afterwards to get them over that extubation hump. All right, so a little summary of extubation. Again, there's all kinds of criteria. This on the right-hand side is our policy for extubation. So you're covered. All right, there's a policy that we help develop to make sure that everybody's on the same page. The RN and the RT know what's what. We all sign the competency. We all know what the SAT screen and SAT failure are, what the SBT screen SBT failure are. It's the same thing I just told you. Right, so we do it every shift, and we make sure they meet criteria, we go ahead and take the sedation off. Then RT is invited back after how many minutes? 30 minutes, and RT does their thing for how many minutes? 30 minutes. So ideally in an hour, if they're on full dose sedation and fentanyl and such, you can have them extubated if they meet criteria. Okay, so again, if they have adequate oxygenation ventilation, is their ABG decent? Is their mental status decent? Are they able to cough and manage secretions? Are they hemodynamically stable? So these are, there are guidelines, and it's ultimately up to the provider to decide on whether to extubate or not. There are different mnemonics here. They haven't been sold in all of them yet, but just for your information, you're looking to see, is the mechanism of injury solved? If they came in with a massive GI bleed and hemorrhage and everything, and they vomited, and they had an EGD that day and were scoped and clipped and everything, and now it's the next day. It's like, oh no, they just got EGD yesterday. But they fixed it, right? Yeah. So we can just take it off, right? Or if they have like a pneumothorax, and that's why they got tubed, right? Then the pneumothorax is fixed, right? They got a chest tube right there. Let's take the tube out, right? And it's always usually better to extubate before you take the tube out too. Okay, so we're looking at the mechanism fixed. Is the airway good? Like the previous slide, were they a traumatic intubation? Let's do a cuff leak if you're really concerned. If there's a leak, then great, we're just to take it out, right? If there's no leak, then we're going to give steroids and pull it in 6 hours, right? Are they able to cough secretions up? And do these really have a lot of evidence? Not really. It's pretty weak to say that, oh no, they got secretions, we can't take it out. There's not a lot of evidence that that's a true story, right? By the same token, conscious level is not a big thing, because you probably had a patient that came from like a nursing home, and they can't solve +2+2. They're out, but they're breathing, right? They're able to cough when they're able to, right? So that is something that is not always even coughs on there too. If they have are they able to expectorate? Are they able to breathe on their own? Do they have a good RSBI? Then they are able to do this, right? They can't, again, they don't have to solve calculus and linear algebra to be able to be extubated. They have to be able just to have good fluid balance. They have to have a good RSBI. They have to have a good improving hemodynamics. They have to look good, basically. That's kind of the take-home point. They look good, and RSBI is good, take it out, right? And then we kind of think about that, the stridor piece, right? If they were multiple intubations, like during that vomiting of GI bleed, they couldn't get the airway, he aspirated all the GI contents, and they were female, or she was a he, and then now they have all these problems, right? They met kind of criteria for someone that might have stridor after extubation. Okay, so if he keeps failing, right? You gave him 3 strikes, and they keep failing and failing and failing, it might be due to like a COPD patient up here, right? COPD patients are difficult to extubate, but what's one of the strategies we can use for someone who's COPD and they keep failing and failing and failing?
Extubate to BiPAP.
Yeah, extubate to BiPAP. So BiPAP is usually a good thing that can help him get over the hump, right? So if you do reintubate someone, it does have more complications, right? There is a 27% mortality when you reintubate someone. But as long as we followed all the criteria ahead of time, then we know that we're doing the right thing, right? So how you failed? It's been 7 days from the first SBT, or they failed 3 SBTs. That is someone that is pretty much failing, and they need to probably be put on a tracheostomy at this point, right? So again, reason why we keep repeating SBI or RSIs, this be repeating SBTs and such. Why do they keep getting reintubated? Why do they keep failing SBTs? Right, they have acute cardiac dysfunction. They have a problem with our RV, for instance. Right ventricle is working against that positive pressure. That could be it. And like we mentioned, like they extubate, and then now what happens? They had all that positive pressure in the chest. It goes away, and then what? It's YOLO, right? Preload's like whoosh, it's going to flood right in, and they're going to get a flash pulmonary edema. Mm-hmm. Okay, so that's something that can happen especially with someone who has really bad heart failure. And thyroid is something to consider. So the thyroid function is really, really poor. Your thyroid function is important for all cell processes and basal metabolic rate and everything. If your thyroid function is really poor, they're not going to be able to do many metabolic processes that well, including muscle contraction. So we want to make sure that they are good. And your COPD patients actually have higher risk for hypothyroidism also. If your patient's cold, you should probably be looking to see if a TSH was done recently, a thyroid function was done recently. All right, and we talked about critical illness polymyeloneuropathy. That's when they're with muscle failure from day to day to day. They're having this breakdown, right, of muscle each day. And then it's like, well, that's cool. We got them off the ventilator, but you look like what happens after? They leave the ICU. Only 70% recover. The rest are left with flaccid quadriparesis, right? So they are now bedbound for the rest of their life. So it's important to get them off the vent as soon as possible if we can. And COPD patients are at higher risk of muscle wasting because they have more muscle energy expenditure because they're really working much harder than the average bear. Okay. And these guys also have diaphragmatic atrophy just after like 18 hours on the vent. And these guys' diaphragms are not upright anymore, they are flattened. So it's very difficult for them to draw in a breath. Okay. And when you assess them, you can see that they have this on the side. Their accessory muscle use is only like right there on the side where they're like by their spleen or liver. They don't have all the muscle use like you'd expect. And malnourished, your COPD patients in orange here, you can see these guys are also at risk for being malnourished, right? When we talked about like the RQ, the respiratory quotient back in the first lecture, that those patients, you want them to be producing less CO2. You want to have a higher fat diet compared to a higher protein or calorie diet, right? We want to make sure they are as optimized as possible. And then phosphorus. What is phosphorus for? AT phosphorus, right? ATP. So we want to have ATP available. So someone keeps failing the vent, and you're like, well, what's their phosphorus, right? So if their phosphorus is low, then we can replace it and hopefully get them off the ventilator later. Okay. And then there's also COPDers are risk, but also we have patients that have tracheal obstructions, right? They have tracheal injury from the initial intubation, airway resistance problems, especially with emphysematics. All right, they're able to get the air into the patient, but it cannot leave because the bronchus gets trapped by mucus, or it just collapses from that bronchial malacia. Okay, and then again, extubating to BiPAP is going to be helping these guys. It's going to improve their mortality dramatically. All right, so these are your patients that have keep failing and failing. We can see there's something else we can do. Your COPD patients, ideally, we try to avoid intubation in the first place because we know that while on the vent, they are going to fail multiple times. A COPD patient's outcome, right? It's an irreversible process. Their outcome is to suffocate on a ventilator one day. That is their pathway. So we have to be able to, again, before they get intubated, what is their goal of care, right? And then once they are on the vent for 7 days, they keep failing and failing. Do they want to be on a trach? Because if they're on a trach, now then their COPD patient, it's very hard to get off for these reasons also. And they're going to now be bedbound. And when you're bedbound, you have all kinds of complications, UTIs, pressure sores, atelectasis, another pneumonia, now you're back in the hospital. It's a whole downward spiral that we have to think about and address. So here's an example of the accessory muscle use here. So you can see on the sides there is just where he has the accessory muscles comparatively to someone who's able to have, bring up the upper muscles, up the scalenes and sternocleidomastoids. All right, so tracheostomy. So who needs a tracheostomy? It's day 8, right? So day 8, they were considering tracheostomy. They failed 3 times on the SBT. It's probably time to consider tracheostomy as well, especially if we're getting later in their ICU course.
Day 8 with 3 fails, or just day 8?
Usually day 8 is usually that's kind of a consideration because they might be just really sick at that point, or they failed 3 times and they're just not passing. Okay. So what else would you need it? They have upper airway issues. Sometimes you can even do an early trach, like day 2, day 3 of intubation, if they have like a catastrophic stroke of some sort. It's like, this is not going to recover in 7 days or 8 days. We should just do tracheostomy now. So who can get trached? It's someone that has good vent settings. So 60% PPA5 usually is when someone who's doing the tracheostomy is going to feel comfortable because oxygen is in there and you're cauterizing vessels. When you cauterize, that's fire source. So we want to have as least fire chance as possible on these guys, right? So what's the benefits of having a trach? It's a much smaller, dead space compared to an ET tube. An ET tube is like a whole snorkel is coming out, and then whereas a trach is just 2 to 3 inches. So it's much easier to improve someone's respiratory dynamics when they have a tracheostomy versus a ET tube, right? It's more comfortable, right? It says patient reports. Sometimes we think that we're the ones saying, it's going to be more comfortable, but patients report it's more comfortable as well, right? Compared to an ET tube that's going across your gag reflex, and it's then you can't really mouth words that well. It's a whole thing, right? Whereas when you're tracheostomy, you can even transition to what's called a passing Muir valve, where they can actually start talking. Okay, mobility, they can mobilize a lot easier with that compared to an ET tube. They can wean again much quicker, and again they have a swallow reflex return. Now they have time to build that up, and they can even eat while they're on a trach. The patients that can swallow with an inflated cuff on the trach are very talented, but we can also sometimes we'll deflate the cuff for their meals. Okay. What are cons to having a trach is there's a big bleeding risk, there's an infection risk. It can stenose, like we talked about in the previous slides, where we have tracheal stenosis or an esophageal fistula or something to that effect. Those things can develop as well, especially if we're not paying attention to what causes those injuries. This guy right here, the cuff is way too high. That's going to start it's going to start eating into the tissues, right? And then what should the cuff pressure be? Less than what?
30.
Less than 30. So less than 20 or 30 is the Goldilocks zone. And basically, they say that it's called the minimal occlusive pressure. So just enough so that where they stop talking, right? So routine care that we have to do for the patient, we have to make sure that we do trach care every shift. So every shift we are also documenting it because that tells you that you did it, right? So we're documenting that we're changing the inner cannula every shift. Some patients have their own inner cannula. They have like a weird model, and that gets cleaned. It's just a clean technique. Otherwise, we're changing the whole tracheostomy inner cannula, okay? Because there's an inner cannula, and there's you could say outer cannula, right? There's the actual trach itself, and then inside we put this inner cannula, okay? And that inner cannula is what gets changed out because that's what gets all grody with crusties and mucus and everything, okay? Because it's happened where we put patients like on the floor where they don't do as intensive care as they would in the intensive care unit, and they're unable to suction very frequently, or they don't put humidification on the oxygen, and their tracheostomies can get occluded and they can code on the floors. Another reason a patient can code on the floors or in the ICU is the trach just gets dislodged, right, or disconnected from the ventilator. Is the most common probably. And then the next part would be it comes out completely. So how do you prevent the ventilator from being disconnected? Buy some super glue. How do you get that, prevent that from happening?
Just make sure it's clipped.
So there's no official clip. This is like a design flaw. This should be developed on the plastic already, right? But we just buy this thing from the 99-cent store. It comes with a package of 3. It's a little, there's a trach tie you can use to keep the trach in place so the whole thing doesn't fall out. But the ventilator itself disconnecting, right? From the, what I'm talking about, we have the ventilator itself just comes right off, right? So how do you prevent that? We have these little clips from the 99-cent store. They look like, where are they at here? I thought I had a picture of them. But they're just going to clip right onto the ET tube. It's going to be Velcroed on itself, and it's going to kind of just anchor it in place, right? We have them in the garage, right? It costs us $5, but it saves lives, right? So it's something that's able to prevent the vent from being disconnected. And then there's the ventilator going off, it's going off, it's going off. What kind of pressure alarm will you see on the screen?
Low pressure.
A low pressure alarm, right? So that'll let us know that we're probably disconnected, right? Or worst case, you finally walk in, and the trach's on the floor. It's like, oh. So what do I do? Do you put it back in?
Yeah.
No. Please don't put it back in. So what do? You hit 0, you call the obturator, and you get the obturator, and you put it in the hole, okay? Because that hole will occlude, right? They'll seal back up. You definitely want to let somebody know. You want to let RT know. You want to let the provider know because they're gonna probably try to put it back in, right? But it has to be put back in under bronchoscopy or fiber optic. They have to view that it's actually going in, because otherwise it can go into the space right above it. It can damage the artery that's right there, an innominate artery, or it can start causing massive subacute emphysema, which we've seen, where someone tries to put the trach back in and they put it into a false lumen and they put the ventilator on, 400 cc's, 400 cc's, 400 cc's, and they just fill up, right? So to make sure that we have the obturator, which is a device. It's not, you don't call 0, I'm kidding, right? So you call the RT, you call your provider, your charge nurse right away to come to the room, or you hit the little code blue button. It's like, I need help in here, right? So there's like, where's your obturator at? It's like, no one told me about the obturator. No, you're letting know right now you have to have an obturator at the bedside, right? You also have to have like a new trach box, a little box with the whole deal in it. So they can then salvage it, and they can open it up the same size, and they can try to put it back in if they need to. They might have to orally intubate in the meantime, or even put an ET tube into the trachea. Okay.
You bag stomach or seal over.
They still have an airway, right? So the reason, like in our ICU, the reason someone's on a trach is because they're like a COPD patient or advanced CHF patient or a pneumonia patient. So they still have an oral airway. When you have patients like we had over there, where they have a base of the tongue cancer, you're really screwed at that point. You can't. Yeah, you could try the upper airway, but that's a real emergency where you need to have someone there to even do like a cricothyrotomy to get tracheostomy access.
Gotcha.
But that's why we have the obturator. The obturator you can put in, right? And hopefully then they're going to go into bronchoscopy to make sure it's in the trachea, and then they're going to, exchange it out.